So, on a Thursday morning, a couple walks into my office, a very beautiful couple at that, dashing, strong man. We have a seat. It turns out they've had infertility for about 3 years. And as we talk through it, it turns out that the male partner has at some point took steroids, so testosterone for gym. And so after speaking to the couple, it becomes clear that the male partner is there primarily to support the wife. So he's very proud to be there for his wife. So we start the workup, which we'll go through. Now it turns out that once we did a semen analysis on the male partner, there was no sperm in the semen. So now this becomes now a problematic thing, because now the male partner was adamant that he's there to support the wife. We'll get back to my story. So I'll be talking about male infertility. And as already mentioned, I will self-advertise. So I'm from Femicare Fertility in Pretoria. So the definition of male infertility is the inability to produce and deliver by normal sexual intercourse and ejaculate containing spermatozoa with the capability of causing conception in the partner at a normal rate of about 20% per month. So it means that normal female partner, normal male partner, trying to fall pregnant, have an underlying fertility rate of 20% each month. So according to the WHO, 1 out of 4 couples in developing countries is said to be affected by infertility. But we know that in our setting, it's more around 1 to 6, 1 in 6, rather. So of that cohort of patients, in other words, the patients who are struggling with fertility, 43% of those patients have a male factor. So the problem is with the male. So that's about half. That's almost half. Yet most of us have sat here for 2 days. We've spoken about polycystic ovarian syndrome. We've spoken about endometriosis. We've spoken about tubal factor, IVF cycles. And this is the first talk on male infertility. Yet half the time, the problem is with the male. So in Africa, we have a problem. And our problem is that of barrenness and plenty. So you get those couples who are fertile having lots of babies. You have 6, 8 babies. And those obviously who have problems with fertility having no babies at all. So we have seen an increase in infertility, especially looking at Southern Africa, North Africa, West and Central Africa. There's a map that I'm going to show you later just to shock you a little bit. So we know that over the years, from about 1970, we've seen a decline in our fertility rates. So just to highlight how bad the situation is for the male, in 1989, 64% of normal-looking sperm was considered normal. Now we're looking at 4%. So if you have 4% of normal sperm, which means 96% of your sperm is abnormal, you're still considered to have a normal semen analysis. Interestingly. Now, just the comparison between us and our primate cousins, they have about 10 times bigger testicles, and theirs they hang in the open. And so they have much more sperm compared to us. So our normal is about 39 to 250 million per ejaculate. So we've seen, with the changing of the times, we're wearing tighter underwear, tighter trousers. There's an increase in obesity. There's more exposure to toxins and heavy metals. And believe it or not, even your cell phone. Cell phone has radiation next to your pocket, killing the sperm as you're walking. There's an increase in drug and steroid use. There's now hot tubs and spas and saunas killing sperm. There's laptops on your lap killing sperm. Smoking and alcohol consumption has also been on the increase. So all of these things contribute to the decline in the quality of sperm that we see today. And this is just to highlight body habitus. With an increase in your BMI, you get an increase in estrogen levels, and that lowers your testosterone level. So it's bad for both male and female partners. So speaking about fertility trends, the green line illustrates the threshold for keeping up your population. So in other words, replacing the dead population. So all those countries where the fertility rates, then that's in red, that's the more recent one, are below that line, it means there's a decline in the population. Now looking at Kenya, which is our closest relative, the fertility rate has halved, but it's still above the green line. So the population, they're replacing their population. So they're going up. This is the map I was talking about. Now these are fertility rates, 1970 versus 2014. And you can see that Africa was very fertile in the 70s. And now we're starting to see a decline in that. So South Africa is looking at 2 to 3 babies per couple. And that's overall. And that's in 2014. So although looking at Africa, comparing it to all the other continents, we're still doing well, there's still a decline. So there's an overall decline in fertility rates. And this has resulted, and you've heard a lot about this, there's an IVF boom. So in countries like Sweden, 5% of all newborns are conceived through ART. And we're going to see that trend going higher and higher. So in those countries, in the European countries, some of them you don't pay for IVF. That's how dire the situation has become. So it's subsidized by the government. So why male infertility? As I said, it's a blind spot for us. I mean, I've attended many conferences, and usually there's one talk on male fertility. One talk. So what I will be covering is then an overview of male fertility. And we know that with a decreasing fertility in the male, there's an increase in how unhealthy you are. So you get, if you're infertile, there's a 30% higher risk of developing diabetes, 48% higher risk of developing heart disease, 19% higher risk of developing depression, 67% risk of abusing drugs. So overall, your health declines as your fertility declines. So it's an important factor. So like I said, about half the time when we see a problem in our investigation of the couple, about half the time the male is responsible. So before I get into the nitty-gritty, I thought I should just have an overview of sperm formation or spermatogenesis. So us men, we're different from females. So females, you're born with a certain number of eggs. Over time, it's decreasing. So I'm sure you had a slide previously with one of our other speakers, where at 40, there's a huge decline in your fertility as a woman. So us men, we make sperm. So every 74 days, you make a new batch of sperm. So let's talk about sperm formation a little bit. So you get your brain producing GnRH, which is gonadotropin releasing hormone. That tells another part of your brain, which is the anterior pituitary, to make gonadotropins. So the IVF lecture before, the FSH and the LH that they were talking about, those are gonadotropins. So you produce those normally, men and females. So LH for men starts first. It takes more precedence. So it acts on the Leydig cells, which are in your testicles. So your testes, your Leydig cells now have LH in them, and that tells the Leydig cells to make testosterone. So the testosterone that's in the testes is different from the rest of the body. Once that testosterone is made, then it goes into your Sertoli cells, which is the male equivalent of your granulosa cells, and then you start making sperm. So it is under intratesticular testosterone. Then FSH comes in and acts on your Sertoli cells, which means now proliferation of that sperm. So FSH proliferates sperm, so you make more sperm. But you cannot make sperm without intratesticular testosterone, okay? I'll get back to that a little bit later. So we know now that from the WHO 2010 semen analysis parameters, which were updated 2018, you have high DNA damage, high aneuploidy, low fertility, high birth defect rates, and high pregnancy loss rates in the sperm that we have today compared to previously. I will speak a little bit about endocrine testing a bit later, so I'll come back to a similar slide. So just to simplify matters, oligosospermia, decreased count. So low sperm count is oligosospermia. Teratosospermia means an increase in your abnormal sperm, so a decrease in your normal sperm. Does that make sense? So less than 4%. We're talking about the 4%. That's the WHO. And then adenospermia is motility. So we want sperm to go forward. Sometimes it swims sideways and backwards. So how did the WHO come up with these parameters? So the parameters we're talking about is the lowest 5%. So it's the 5th centile of the cohort of men that they tested. So it means these are the worst of the worst. So if we're looking at you just making normal, it means you are 5% of normal, the lowest 5%. Now, when it comes to causes, to simplify things, we're going to talk about pre-testicular, so before the testicle, testicular, and post-testicular. Okay, so pre-testicular means central. It means something is wrong in the brain. Those hormones we're talking about, FSH and LH, there's something wrong with those hormones, or GnRH. Okay, so all that's just a summary of the causes. The testicular causes involves the testicles. Now this we will dwell a little bit on because these are sometimes reversible. So you've got your varicocele, trauma that one of the speakers was speaking about, and infections. Chromosomal abnormalities, which is why it's important. Part of our workup, secondary workup, is that we do a chromosomal analysis of the male. And then the post-testicular is plumbing problems. So you're making sperm, but there's a blockage somewhere in the system. So you can't get the sperm out of your testes. This one is usually the easiest to treat because you can just go to the testicle and suck out the sperm. Okay? So the majority of our patients, we don't find the cause. Those patients, that's everybody who comes into our clinic, comes in with a fertility issue. 34% of them, we don't know what the cause is. There is something else. But of those that we do find the cause, varicocele in males is still number one. And then those are the rest of the other causes. So hypogonadism, which is a passion of mine, but we'll get technical a bit later about hypogonadism, which we'll talk about. So the problem, and this is now a societal problem, is that women wait for Mr. Right. And we know that the longer you wait, the more abnormal eggs you have, and the less the number of eggs you have. But it's not just the woman. I might be guilty of this. Waiting for Miss Right is also a problem of ours. So there's such a thing as advanced paternal age. So you get altered functions of the GnRH, which is the first signal that we spoke about in the brain, which leads to diminished testicular response to gonadotropins. And then you get your diminished hypopituitary response. And as the testosterone goes down, you get an increase in your sex hormone binding globulin, which binds to testosterone, which means there is less available testosterone to do the work, which then further declines your fertility rate. And all of this obviously leads to sexual dysfunction, muscle wasting, increased fat to lean body mass. It's my father who has a big belly and very thin arms. I'm sure it's very common in South Africa. Osteopenia, loss of body hair, impaired hematopoiesis, and memory loss. And I put Donald Trump there to illustrate the fact, because his father was 41 when he had him. So it illustrates the point that there's increased chances of having offspring that have problems if you have increased paternal age. And there is no guessing. One of our past presidents is also had an advanced paternal age, and there's no prizes for guessing who that was. Now, an approach to male infertility, we need to standardize the approach, and the approach hasn't changed much over the years. Still history and physical examination, and gynecologists hate this, but this means that you need to measure the testes of the male. And it also means that you need to do an ultrasound of the male, which we avoid, but we shouldn't. And then the next step is usually doing a semen analysis. So the semen analysis gives us a guide, because we know that if the semen analysis is normal, your hormones and your chromosomes should be fine. Okay, so we only go on to that step if your semen analysis has a problem. Okay, so, and now back to the couple I was speaking about. It was very traumatic for the male partner finding out that there was no sperm in his semen. Now, the initial feeling, and this was shared, was that you feel less like a man. There was a video that was played earlier where a womb man, that was a very interesting video where the presenter said that she felt half like a woman. So the same thing happens to the male. But the important thing is that your semen analysis is not a measure of your manhood. It has nothing to do with it. This is a spectrum. So those, I mean, there are many studies illustrating this. So in this study, 52% of men with subnormal sperm parameters still achieve pregnancy in 3 years. So it might take longer, but in most of the cases, you will still get a pregnancy. So you're not less of a man. Even if you don't, it has nothing to do with that. The important thing is that there's an interplay between the male and female partner. So it takes two to tango. There's an interplay. So you can have a subfertile female with a subfertile male still getting a pregnancy. It might take longer, but you can still be pregnant. Okay? Now this is azoospermia. It's slightly technical. But it goes back to the simplified version of pre-testicular, testicular, and post-testicular causes of azoospermia, which the male partner had. So no sperm. So we remember oligo means decrease, but azo means no sperm whatsoever. So we'll get into it in the next slide. So like I said, I'm very passionate about gonadotropin use in males. So you've spoken about IVF in female partners, specifically looking at ovarian hyperstimulation. So because the same hormones are produced by the man, there's a role for them. Okay? So if there's a problem in the brain, that's easy enough. We give them the hormones that are produced in the brain. So the easiest thing to start with, as I said, the LH is the one that stimulates everything. So we start with the LH, which is beta-HCG in our sense. So it's another hormone that has similar action compared to LH. So we start with that, okay? Eventually, we might need FSH, so you need to keep monitoring. And if you need FSH, then you start FSH. Okay, so that's the easiest way with azoospermia. Now, the next thing is if there's a problem in the testes. So if there's a problem in the testes, your hormones in the brain are now increased because they are trying to say to the testes, make more sperm. But the testes are not responding. All right? So in the past, this is where now testosterone used to come in. So they said, okay, if the problem is the testes are not working, let's give you testosterone. Now, the problem is the testosterone in the blood is different from the testosterone in your testicle. So there is a blood testicular blood barrier that we speak of. So your blood testosterone goes up, and that tells the brain that, okay, we have a lot of testosterone now. You must switch off. So you switch off your brain. But your blood testosterone is still high. Your intra-testicular testosterone is low, because that depends on your brain now. So there isn't any of that happening. All right? So now, and this is where it gets interesting. So this slide is to illustrate that when you take steroids, everything gets big except your gonads. You can see the size there is still quite tiny. So it just increases your aggression. It increases your heart muscle, which can block blood leaving your heart, and no sperm. But you look more like a man, eh? Is that? So now the question is, what to do? What should we do as healthcare practitioners? So I won't go through all of this. The point of all of this is that there are options. There is treatment available. And with treatment, you will get an improvement in your fertility rate. Gonadotropins I've already spoken about. I'm going to touch on them again because I am very passionate about them. So clomiphene citrate, which is a selective estrogen receptor modulator, binds on your estrogen receptors, and it has different effects in different tissues. So the point of doing this is to increase your FSH and LH. Okay? So there is definitely a place for it. So we use it. We can increase your intratesticular sperm by increasing your FSH and LH, because that's the triggers. So this previously we used to say the initial results were promising. It's no longer that they're promising. There is a place for it. But more and more we're seeing that gonadotropins are taking a bigger chunk in the treatment of male infertility. Aromatase inhibitors, similar. Letrozole, that everybody hears about. So there's also a place for letrozole in the treatment of male infertility. And this has changed slightly. So we used to use 1,000 units of each HCG, and I told you that HCG is similar to LH. So you must think of HCG in this sense as LH. So now we use from 1,000 to about 5,000 units twice a week for a minimum of 12 weeks, but it can be, which is 3 months. So minimum of 3 months you're on this, but it can be up to 18 months, depending on how you respond. So this is long-term treatment. So the same couple who came in, we started him, after seeing the gynecologist, we started him on HCG. And the first thing he said is that, he said, no, but this is for women, because it says so on the box. But we had to explain to him that it also works for men. So you can use for your secondary hypogonadism. In this day and age, the first port of treatment is gonadotropins. So because that means that your brain is switched off. So there is no place for other things of antioxidants and things. If you're hypogonadotropic, hypogonadism, it means that you're going to start that patient on beta-HCG and possibly on FSH later on. Okay? For your non-obstructive azoospermia, same thing. So, Prof. Estevez, who is from Brazil, is very passionate about the subject. And he found that even in those patients who have non-obstructive azoospermia, you can still, a non-obstructive azoospermia is hypo. You can still use your gonadotropins. There's an improvement in your mean total testosterone, and your mean combined testes volume increases. And mean sperm count went from 0 to about 36, which is a lot. And that's million sperms per mil. I told you that plumbing problems are easy for us. So there are different ways to get sperm out of the testes. There's a move now towards us using microsurgery because that has better yields. So we get what we call micro-tessi, which we used to do. I think the Stellenbosch group used to do a lot of, but unfortunately, Prof. Zarabi, I think, is now in New Zealand. So I'm not sure if there's anybody doing it. But we are trying to get more of our urologists to do it. So we should be having a workshop on it in December at Femicare. And yes, you have seen a lot of pharmacological companies here selling different vitamins, and the vitamins all do the same thing, which is the antioxidants. So there's a theory that an increase in your reactive oxygen species then decreases your sperm count. So then you get your carnitine and psyllium and coenzyme Q10 and different vitamins. And there are different studies that have shown an improvement with different use of antioxidants in your pregnancy rates. But then equally, for those studies, there are also other studies that show that there is no effect for that. So if you're going to use it moderately and don't use it for too long. So 3 months, nothing more. And if all health fails, you're going to come and see us at our fertility clinic, which means we're going to do ICSI. It's an option. Okay. More self-advertising on our part. This is Femicare. And remember, this switch, I like that picture on the right because, you must switch on the male fertility. So currently we are off. Before you come and see us, lose weight, stop smoking, especially marijuana, reduce your alcohol intake. You can take your antioxidants. And remember, the sooner you see us, the better it is in the long run. And as I said, it takes 2 to tango. There's no blame. And that was a big thing. You know, the psychological effects of infertility can never be understated. So the big thing was now for this man who was ready to support the wife. He saw himself as a doting husband, but now he's the one with the problem. It took a lot of therapy for them first to accept, for him to accept that he was the problem, and for him to even start the treatment. It took a few months. And the take-home message, I think, is for the entire weekend, is that it is possible. It is possible to have a baby. It's never lost. Thank you.